Hello everyone and welcome to our module on somatic and factitious disorders. The term somatization refers to physical symptoms that are not explained by medical disease. In addition, the symptoms are not consciously created for gain by the patient. If they are, those are called factitious symptoms, which we'll talk about later in this video. And many patients present to their doctors with physical complaints that cannot be explained by medical disease, and this is sometimes referred to as somatization. Now, this is somewhat controversial because these patients may actually have a disorder. It's just one that we don't understand in Western medicine, but nevertheless, when patients have recurrent chronic physical symptoms that cannot be explained, that is often referred to as somatization. And risk factors for development of somatic symptoms include female gender, less education, minority status, or low socioeconomic status. Patients with these risk factors tend to be the type of patients that present with physical symptoms that cannot be explained. Some of the symptoms that can be seen as a result of somatization are shown on this slide. Many patients have pain symptoms like headache, back pain, or joint pain that medical science can't explain. Many patients with chronic GI complaints like nausea, abdominal bloating, or gas have symptoms that cannot be explained. I see many patients with somatic symptoms of cardiopulmonary syndromes like chest pain, dizziness, or palpitations. Some patients have neurologic symptoms. Some of those are shown here: fainting, muscle weakness, blurred vision. In addition, some women complain of dyspareunia, which is painful intercourse, or dysmenorrhea, which is painful menstrual periods. And in many cases, these symptoms cannot be satisfactorily explained by medical science. Many patients who have these types of symptoms and they can't be explained by a medical disorder and the symptoms are chronic and won't go away, many of these patients also have anxiety and depression. And the management of patients with somatization is shown on this slide. First of all, you want to avoid debating if the symptoms are real or psychiatric. You never want to get in a discussion about this type of thing with a patient. Remember what I said before, many of these disorders are things that we just can't explain yet, and years down the road we may know what causes them. You don't want to challenge a patient's belief that the symptoms are medical. You don't want to say it's all in your head and you don't have a problem. I've bolded this here because this is very important for your board exams. These types of patients should have regular visits with the same physician. The worst thing that can happen is if they keep meeting different doctors who keep reordering the same tests over and over. You want them to meet the same doctor each time, someone who knows them and someone who can assess whether the symptoms are the same, worse, or better. In general, you try to limit tests or referrals once you've excluded dangerous causes of their symptoms. You want to reassure the patient that a serious medical disease has been ruled out. This is something I do often. I have many patients and I can't explain their symptoms, but I let them know that their heart is healthy and that there's no evidence of a dangerous heart condition. You want to set goals of functional improvement. You don't want the patient's goal or expectation to be that they will be cured, but you want their goal to be that they will be more functional and able to do more things. And then finally, psychotherapy, a referral for psychotherapy, is often helpful for patients who have chronic symptoms that will not go away and that cannot be explained by medical science. So what I've been talking about in the last few slides are general principles of somatic symptoms, but now what I'm going to talk about are DSM-5 diagnoses that involve somatic symptoms. There are a number of these, and the first one is called somatic symptom disorder. This occurs when patients have somatic symptoms that cause distress, so this could be anything we talked about in the last few slides. In addition, the patient has persistent thoughts about the seriousness of the symptoms, so they're always worried that they may have something dangerously wrong with them. This can cause them anxiety, and they spend an excessive amount of time and energy devoted to management of their symptoms and worrying about their symptoms. And in addition, it has to be persistent, and the definition of persistent is usually more than 6 months. So a patient that meets all these criteria meets the DSM-5 diagnostic criteria for a somatic symptom disorder. Another DSM-5 diagnosis is illness anxiety disorder. This is a little bit different. This is where a patient has a preoccupation with having an undiagnosed illness, but they may have mild or no somatic symptoms. So this is the type of patient who is always worried that they have a cancer inside of them or that they're going to have a heart attack, but in fact all the workup has shown that they are fine and otherwise healthy. They have lots of anxiety about their health and they engage in excessive health-related behaviors. So for example, they might be repeatedly checking themselves for signs of illness, like constantly measuring their pulse or blood pressure. And this also has to be present for at least 6 months. And if these criteria are met, then this patient meets the DSM-5 diagnostic criteria for illness anxiety disorder. Conversion disorder is also called functional neurologic symptom disorder, and it gets this name because it always involves neurologic symptoms. This condition has a sudden onset, usually following a stressor. The stressor might be a divorce or the death of a loved one or an argument with a son or daughter. This type of traumatic psychologic stressor is what often leads to conversion disorder. These patients develop voluntary motor or sensory neurologic symptoms. So for example, they may say that they are unable to speak or move. They may say that they can't see, or they may even have seizures. However, it's a voluntary problem. The neurologic workup is normal and there's no evidence of a central nervous system disorder. A classic thing to see on exam is a positive finding that's incompatible with disease. So for example, if you ask the patient to lie on the table and they say that they cannot plantar flex, but then when you have them stand, they're able to go up on their tiptoes. This is incompatible with disease. If you can't plantar flex, you can't stand on your tiptoes. And this is the type of thing that you can see in someone who has a conversion disorder. Another classic finding is labile indifference. This means that the patient shows a lack of concern or an indifference about their symptoms. So the classic presentation of this disorder is someone who recently had some type of life trauma and now says they can't speak or see or move. But when you examine them, you identify features that say that they actually can move, they just don't want to. And in addition, the patient seems to show a general lack of concern about what appears to be severe symptoms. We'll finish by talking about factitious disorder, and I'll start by talking about what's known as a factitious disorder on self. This is also sometimes called Munchausen syndrome, based on a literary character named Munchausen who used to make things up. Factitious disorders are falsified medical or psychiatric symptoms, and a patient does this consciously out of a desire for attention. So for example, a patient may feign illness, or they may genuinely have an illness and they aggravate it on purpose in order to get attention. And patients who have this condition are often willing to go for tests or surgeries because they like the medical attention that they get from having the falsified condition. Munchausen syndrome, or factitious disorder on self, is done by the patient for primary gain from illness. And by primary gain, I mean an internal gain. So the patient feels better in the sick role, and the sick role may involve some type of internal conflict. So for example, patients who are afraid of work may feel better by having a disorder that allows them to not go to work. Or patients who are afraid to be alone may be happier in the hospital because now they are surrounded by others. It has to be chronic and persistent to meet criteria for this disorder. And risk factors are female gender, being unmarried, and being a prior or current healthcare worker. Healthcare workers are often aware of the healthcare system and the type of tests and procedures that are out there, so if they develop disorder, they can seek things out. One case I saw during residency was a person who worked in the infectious disease laboratory who was injecting herself with bacteria to make herself sick because she liked the attention of being in the hospital. Obviously, this was a woman who was very disturbed and needed psychiatric help, and she had a Munchausen syndrome, or a factitious disorder on self. Closely related to Munchausen syndrome is Munchausen by proxy. This is also called factitious disorder on another. This is where falsified medical symptoms are made up by a caregiver. It's often by the parent of a child or the caretaker of an elderly person. The caretaker makes up symptoms, for example, says that the child is sick, or even makes the child sick, or someone who says that their elderly parent is sick, but it's made up. This is a person who is suffering from Munchausen's by proxy. And lastly, let me mention malingering. Malingering is when a patient consciously falsifies medical symptoms, but in contrast to Munchausen syndrome, they do it for secondary or external gain. For example, by making up symptoms, a patient might be able to miss out on work but get paid, or they might be able to obtain workers' compensation. This is something that's often done with musculoskeletal injuries. Some patients will fake these injuries in order to get compensation for an injury at work. What distinguishes this from factitious disorders and some other problems are that it is self-limited, and it's going to end when the secondary gain is achieved. So for example, the patient with Munchausen syndrome will chronically like being sick because of the gain that they get. The person who is malingering, once they get the check for workman's compensation, their symptom is going to go away. That is malingering, not a factitious disorder. And that concludes our module on somatic and factitious disorders.